Welcome to the InTouch Health webinar series. This is Rachel, and I will be your host for the webinar. Today we will be featuring Dr. James Connors and Joshua Bach from Rush University Medical Center, and they will be presenting the more than 5-year history of their Telestroke network with a focus on feedback and coordination of spoke hospitals. Dr. James Connors is an associate professor in the Department of Neurological Sciences at Rush University Medical Center. He is head of the section of cerebrovascular diseases and medical director of the Comprehensive Stroke Program, Telestroke, and the Mobile Stroke Unit. He received his medical degree at the University of Illinois College of Medicine at Chicago and a Master of Science degree in neuroscience from Loyola University. He then completed a medical internship, neurology residency, and vascular neurology fellowship at Northwestern University. We also have Joshua Bach, who is the Director of Neuroemergency Programs at Rush University Medical Center. He's the Administrative Director for the Rush to Brain Neuroscience Transfer Program, as well as the Rush Telestroke Program. He has over 10 years of experience in building telehealth and referral outreach networks. We'll begin our webinar shortly, but first a few notices. You've all been auto-muted. If not, please make sure you mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area, or by dragging the bottom right corner of the slide area. During the webinar, you will be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website, and a link will be posted at the end of the webinar to your email addresses as well. This webinar presentation should last about 60 minutes, including time for questions and answers. And now, without further ado, here are Dr. James Connors and Joshua Bach.
All right, thanks so much, Rachel, for the introduction. So as she mentioned, we'll be talking about Telestroke networks, and optimizing your networks with good communication with all of your network sites. So to begin, anytime there's a new technology, we always want to make sure that there's truly a need for it. And I think that certainly we've been able to prove that with Telestroke for the following reasons, and I'll go into a little bit more detail on each of these. But first of all, acute stroke, it's common and costly. We do have treatments that are effective, but these are all time dependent. However, there is limited access to stroke specialists, and this leads to decreased acute treatment of our patients. So again, as I mentioned, ischemic stroke, it's very common. One stroke every 40 seconds in the U.S., almost 800,000 strokes annually. 1 out of every 6 Americans will be affected in their lifetime. Say every 3 minutes, someone actually dies of a stroke. And currently, stroke is the 5th leading cause of death, so that's improved over time, over the last few years. However, just as important, stroke remains the leading cause of major disability in adults in this country. And the estimates are approximately $73 billion a year, so really a staggering impact from that standpoint. As I mentioned, our treatments are time dependent, and this really is due to the fact that every minute that goes by of a blocked blood vessel, you're losing approximately 2 million neurons as well as 14 billion synapses. So that leads to the mantra that we always say is time is brain. And as I mentioned, we have established stroke therapies that are effective, but again, because of what we talked about in the last slide, these therapies are certainly time dependent. The first one is medical therapy with IV-TPA. Again, most of you are probably familiar with this, but it's our clot-busting infusion, and really needs to be administered within 3 to 4.5 hours from the onset of symptoms to really be effective. When we do use it in the right patients, The treatment results in about 60 to 70% increased odds of a favorable outcome at 3 months when you compare that to placebo. And we've been able to use TPA for about 20 years now. More recently, we've been able to add endovascular thrombectomy to our stroke armamentarium. This is for more select patients, patients who have suspected large vessel occlusion. We have a little bit longer time window for these patients, typically going out to about 6 hours. But again, these are for a specific patient population. For patients who have a large vessel occlusion, typically we're talking about a carotid T or a middle cerebral artery occlusion. We know IV TPA therapy by itself can recanalize the vessel up to 40% of the time. But when we add on the endovascular thrombectomy, our rates go up to over 80%, and certainly this leads to improved outcomes. And again, these are our patients who have the biggest stroke syndromes to begin with, and so we can really see some dramatic effects. Both of these therapies come with a risk of symptomatic hemorrhage, though, and because of that, we really want to make sure that we're treating the right patients, that we're truly treating stroke patients, and that we're optimizing any treatment options. And again, this is one of the reasons, as I mentioned earlier, why Telestroke is important. Only about 40% of emergency physicians, 40% of emergency physicians were reluctant to use TPA without a neurologist also seeing that patient. That said, there aren't enough neurologists to go around in the country. Only about 4 neurologists per 100,000 persons in the U.S., and again, this is caring for more than 700,000 strokes a year. Even less likely to have is to have a stroke specialist, so a vascular neurologist. These are neurologists who then have extra fellowship training. And in 2006, there were 32 fellows in the U.S. That number went up to 107 in 2014. But when you compare those numbers to something like cardiology, where there were over 2,000 fellows, you can see why there's really a lack of that expertise out there to see these patients. So that leads us to where we are today with the reality of acute stroke treatment. First of all, only about 25% of stroke patients arrive within the 3-hour time window to get to the ER for possible treatment. This is for various factors, but a lot of it has to do with public knowledge of stroke symptoms, awareness, and then also when to call 911. That being said, though, only 25% of eligible patients who are in an ER, these are patients who called 911 and they got to the emergency room, only a quarter of them are getting TPA. Again, this is for various factors that we're constantly working on, but a lack of necessary infrastructure is certainly one of them. And there was a nice paper that looked at estimating how many patients could get TPA if everything went well. So what they found was that if everyone with a stroke called 911 at their symptom onset, and they were also taken to a hospital that was prepared to treat them, then about 50% of patients would actually be getting TPA. That said, currently we're only at about 5% of ischemic stroke patients that are being treated with thrombolysis, so certainly a lot of work to do. So just to briefly recap, with ischemic stroke, we have a disease state that's common and costly, that has high rates of morbidity and mortality. We do have effective treatments, but they need to be done emergently. And it's the access to stroke specialists, as well as hospitals that are ready to treat them, that has really limited us in our ability to treat these patients. So with that in mind, in 2009, the American Stroke Association came out with a policy statement recommending establishment of telemedicine within stroke systems of care. And this was to address those current barriers that we mentioned in order to improve overall stroke care in the U.S. So I just wanted to highlight some of their main recommendations. The first one, which is probably the most important, is that telestroke should be employed when 24/7 coverage is not available, or where access to stroke expertise cannot occur in a timely manner. So this is really going to end up being most hospital facilities where you don't have a neurologist who's on site. Also, Telestroke providers should have appropriate levels of expertise in stroke care. And the organizations requesting the Telestroke consultation, so this is in a hub and spoke model that we talk about, where the hub is the site where the Telestroke physicians are and the spokes are the hospitals where the patient are. Those hospitals really need to be able to provide the elements of emergency stroke care that's typically defined by primary stroke center recommendations. So they need to be able to give TPA, et cetera, and treat those patients if those are the recommendations by the specialists. To give you an idea about the status of Telestroke in the U.S., there was a study done in 2012 reviewing this. At that time, there were 56 programs in 27 different states. The number one clinical need that was met by Telestroke programs was ED consultation, with that being 100%. And then patient triage not far behind that at 83%. And less than half of overall Telestroke programs were using it for inpatient Telestroke consultation. Over a time span, they did see growth of these programs. So from 2007 to 2009, the programs almost doubled in size. And that's pretty typical as you start your program out and then slowly grow. Interestingly, in this study, and again, this was from 2012, they found that over 80% of their spoke sites were rural or small hospitals. And I think that, as you'll see when we discuss the Rush Telestroke program, is that this is a need even in urban areas. As I mentioned, it's really a need in any hospital that doesn't have on-site neurology. So to segue into the network that we have, we started in 2011, and by the end of that first year, we had 5 sites. Started slowly. We had our first consultation in March of 2011. I think waited about 3 weeks until the next call came in. But as we've been able to grow through the years, we are now at, as you see here on this map, we've had 10 sites, and then this doesn't incorporate the 11th site that we just added this year in 2017. So to give you an overall idea as far as our numbers, as I mentioned, 11 hospitals within the hub and spoke model, and that would be with Rush being the hub site. 8 of our hospitals are actually primary stroke centers. So again, this speaks to the fact that even if you're a primary stroke center and you're otherwise doing things well, it's difficult to have that emergent neurology consultation. So this can certainly helps our hospitals, our primary stroke centers, reach their numbers that they need. We've performed over 3,200 consultations since March of 2011, and currently we're averaging about 65 consults a month. So you can see from when we started until where we are now, the program has certainly picked up and become quite busy. One of the numbers that we're very proud of is that almost a third of our stroke patients are receiving IV TPA. And again, this is in comparison to the 5% national average, so it can certainly be a benefit to the patients in your community. Another important point about our program is that 86% of patients actually remain in the community. They don't need to be transferred. And I think this helps, again, patients stay closer to home. They're able to be treated in the hospital where they initially went into the emergency room. And again, if it's a patient who doesn't necessarily need comprehensive care, we'd prefer not to transfer that patient because we'd prefer to be able to keep beds in our neuro ICU open for those patients who really end up needing that higher level of care. Currently, we have 5 stroke neurologists. We're adding on another one. We're growing our group as the Telestroke program grows. This to give you an idea of the basic model of what happens with a Telestroke consultation. Most of you are probably aware, but a patient presents into the network hospital emergency room where they suspect a stroke. Either it was EMS pre-notification or they suspect it at triage, and they start their own stroke alert protocol. As soon as it's determined that this patient likely has an ischemic stroke, then they are calling a direct line to the vascular neurologist who's on call, who can then hear a little bit about the patient and then beam in from wherever they are to examine that patient remotely, to review the patient's electronic medical record, look at labs if necessary, as well as use remote viewing of a PAC system to look at the head CT and confirm what the radiologist sees. Treatment decisions are then made after a discussion with the ER physician and the ER staff. If the patient needs IV TPA alone, that's recommended and that's initiated. If it's a patient who appears to need comprehensive stroke center, so either endovascular therapy, or if it looks like it's malignant MCA territory where the patient might end up needing neuro ICU care for watchful waiting of cerebral edema or hemicraniectomy, then what we'll do is recommend transfer of those patients and transfer them accordingly. This gives you an overall picture of the program growth. So as I mentioned, in 2011, starting with 2 spokes right off the bat until 2016, now with 11 spoke sites, and you can see pretty rapid and sustained growth in the total number of consults. Our overall TPA rate has hovered right around that 30 to 35% rate, and the transfers have slowly increased as well. So again, overall a program that's seems to be working well, and we really think that it's having a beneficial impact on the spoke sites as well as obviously the patients in those communities. And with that, I'm going to hand things over to Josh.
Great, thank you. So just a quick background on Rush. We're an academic medical center, 679 beds here in Chicago. We have Rush Health System for many of you that have existing networks. You provide consultation to partner sites both within your system and independent partners. Within our system, we provide consultation to Rush Oak Park Hospital and Rush Copley. Other sites within our network are independent hospitals or health systems. And Jim mentioned this briefly, but just the landscape in Chicago, slightly unique. 5 academic institutions within the city, a great number of comprehensive stroke centers. So stroke resource within the greater Chicagoland area may reflect your network or may not if you follow that more suburban and rural model. When we're going to get into education and feedback, just to give you an idea about our program, we're able to leverage the resources that exist at a number of our partner facilities. That may or may not be the case within your network. The one statistic that Dr. Connors mentioned is that 25% of stroke patients, only 25%, arrive within that 3-hour treatment window. So education, community education, is one of the most important things that we do within stroke, and as that relates to Telestroke. So we're not going to focus a lot on that portion today. We're fortunate enough to be able to rely on a lot of the community resources and education that our partner sites have in place. We certainly encourage that collaboration, like to participate in those. That won't be a focus of this presentation, but it's certainly a focus of our program and on all of our partner site programs as it relates to stroke in their communities. So it kind of reiterates what Jim talked about, but ensuring success within your program, we have a dedicated clinical team as well as administrative support for developing and improving our program, rapid assessment and treatment. And then what we'll focus on for the rest of the presentation, primarily the bottom 3 bullet points, mechanisms for feedback, both from the hub to the spoke or from the originating sites to your Telestroke team, having a structure in place for QA, improvement, regular meetings between institutions, best practice sharing, and the goal is creating a true system of care. Let's talk about some of the regular reporting that we do. These are things that we have in place. Monthly data, often just electronic email communication to each of our partner sites that includes the number of consults, transfers, TPA, and then a specific spoke request. This may be at each institution. It varies. Oftentimes, depending about the structure of their primary stroke center, they may need to document reasons that TPA was not given for stroke patients. So we have different requests for each of our sites, but on a monthly basis, we're emailing that communication out. We participate in the stroke committee meetings in some fashion. Sometimes it's just conference call, in person as often as possible. We also send out a quarterly letter and then a semi-annual executive summary, and I'll go into more detail on those. But that's the regular reporting that we do. Included within the Telestroke program, we provide a transfer feedback for all neuroscience patients. In the introduction, we talked about our Two Brain program. That's a dedicated neurotransfer program that's run by our neurointensivist in collaboration with the stroke team for any neural emergency. So on a monthly basis, these letters go back to any of our referring sites, whether they have Telestroke or not, and they provide the diagnosis summary, any treatment, as well as discharge disposition. It's targeted at an emergency department medical director, a stroke coordinator, and this is something we're actually looking to improve. We feel that this may not be as meaningful or as timely as we would hope, but certainly providing to your network sites feedback on patients. And at the emergency department level, the questions that we most often get are, what happened to that patient? Did they receive a procedure? As they're sending patients to a comprehensive stroke center, they certainly want to know what higher level of care was provided. So the quarterly reporting that we do, again, goes out to clinical leadership, emergency department director, nurse manager, stroke program coordinator. They may have a neuroscience service line director or an other administrative contact. More and more we're seeing this reporting go through quality. And this is a data summary for each of the sites covering the quarter, consults, TPA given, but also a number of the key time metrics that for your sites that are primary stroke centers, of course, they're tracking those door-to-needle times. And we also provide a comparison to the network overall, which allows them to benchmark themselves against the rest of the network. Also included in this report is a diagnosis summary, giving them an idea about what type of patients are presenting, and any key announcements that we may have, certification, for example, our Comprehensive Stroke Center certification, upcoming events or meetings, be they rush events or general stroke events. And one of the things that we've begun to highlight is key clinical trials, anything within neuroscience, not just related to stroke. For instance, those of you that are enrolling site for DAWN, the mechanical thrombectomy for patients up to 24 hours, highlighting that this has been a great resource to our stroke champions at each of our sites that they include within their stroke committee meetings, that they then elevate to their leaders to promote their program. Many of these get posted within the emergency department as well. So it's just taking some of the resources that we have here at Rush to highlight the work that's being done at our partner sites. The other regular report that we have is a senior leader letter that goes out on a semi-annual basis. It's targeted at the C-suite. Most often it's going to the spoke hospital CEO. It copies our president and CEO as well as the chairman of neurology, and then that clinical leadership team also. So this is a letter from Dr. Connors. It includes the entire program history, focusing back to those initial conversations that may have been years ago or maybe have been with a different senior leader, the amount of work that we've done, making sure that we're hitting our goals as far as keeping as many patients in the community as possible, highlighting those TPA benchmarks. These are not folks that are necessarily tracking their stroke program from day to day, so it's intended to be high level. Also included in that is a comparative blinded data set, and we take hospitals within the network, similar demographics, so we're looking at ED volumes, are they a primary stroke center, other similarities, maybe they have active neurology, maybe they have essentially no acute stroke coverage from their own neurology teams. And then we provide that data, again, benchmarking them, calling out the key stroke metrics like TPA rate, some of the time metrics, and then how often they're transferring patients. The goal of this, as it says, is to reinforce that program value. And then similar to the quarterly report, we've gotten great feedback from our partner sites. It's helped them with their improvement efforts, promoting their stroke program and their successes, highlighting areas for improvement as they're driving towards that door-to-needle time or whatever their target might be for their own stroke program. So that's some of the regular reporting that we do. Of course, the on-site interaction is equally or more valuable. This includes site visits. Oftentimes we'll target the emergency department nursing meeting for those just stop-bys. Great way to catch new staff, understand what's going on within that unit. From an in-service perspective, we like to participate in that annual stroke education. And I'll talk a little bit more about what we're hoping to do in the near term. Of course, new staff that was not included in the initial implementation, skill development, it might be an NIH stroke scale assessment. And then if your institution allows, coordinate with industry. If you can have Genentech participate in those meetings, and then it becomes a more thorough stroke education, not just about Telestroke or your workflow, more benefit for the staff at that spoke site. We also have grand rounds in CME. Dr. Connors, our vascular neurology team, neurosurgery, neurointensivists are very giving with their time here, going off campus, presenting at each of our affiliate sites. And then lastly, the most formal on-site interaction that we have is an M&M presentation, most often targeted at that emergency department medicine meeting. Sometimes it's a stroke committee meeting, or we'll call out a completely separate meeting depending on the team that needs to be included. And as a part of that M&M, we'll provide data for a 6 to 12-month period. Here at Rush, we coordinate with our transfer center and any other strategic programs. Neuroscience is such a leading program here at Rush. If there are other strategic programs, the time at those emergency medicine meetings is so valuable. Those agendas are often packed. Years ago, we used to have a call from Telestroke and a call from Two Brain, and the Rush Transfer Center is trying to get time at that meeting, and then Pediatrics is trying to get time at that meeting. If you can coordinate what your strategic programs are, whoever's looking for time and feedback, much better for your spoke sites, a much more coordinated effort. So at that meeting, like I said, often a very busy agenda, things that they're trying to cover. Knowing what they want to hear about it. It might just be data. It might be a specific case. They may need workflow help, or there might be a specific effort that they're making on staff education. Also helpful to have any recent history. You're always going to get that story from that emergency medicine physician that I had such trouble transferring that patient in 2009, so you have to be prepared for that. But having your recent history, any cases with great outcomes, any issues, delays in transferring patients, miscommunications, any opportunities for improvement, declinations if you've not been able to take a patient due to capacity. Good to go in with that history and be prepared to speak to it. Included with that, I mentioned the data just very briefly. We'll again highlight the entire program history. This is just an example slide that we used recently that covered all of 2016, just some of the key points that they're used to seeing in your regular reporting, but good to reiterate to that entire emergency medicine team that may not be included within the quarterly or semi-annual report. We cover discharge disposition, patients that transfer to Rush for that higher level of care, giving them an idea about outcomes, really hitting that we're sending patients home or rehab. And then lastly, we like to include a case review. This may be a patient that they asked about, maybe a patient that we want to highlight, or oftentimes this may be a specific treatment that we're offering that we want to highlight. Again, it's a collaborative between the Telestroke team and the partner site about what this presentation may be. This is physician-led, of course, with a full imaging from the arrival to the discharge. Some of the other events that we do for our affiliate sites within multiple programs. We have a neuroemergency symposium we hosted in 2014 and 2015. We'll be hosting in 2017 again. This is an all-day CME event. We've been doing it on a Saturday. We'll bring in a keynote speaker. We have speakers from our sections of stroke, neurocritical care, neurosurgery, pharmacy. And again, the attendees are those that participate actively in our Telestroke programs, our transfer programs, so emergency medicine, neurology, a great way to promote not only Telestroke and what your program has to offer, but other clinical specialties. Last year, for the first time, we had a Telestroke network meeting. This was something we put on at Rush. It was a half-day event. It was not CME. We were actually hoping to do CME this year. Incredible positive feedback that we got from each of our sites. I can't believe it took us 5 years to bring this group together. Again, primarily the emergency medicine directors, stroke program coordinators, the nursing clinical teams from the ED, current sites, and then potential sites, those that we were onboarding or wanted to present the program to. We covered history on the program, did some clinical updates, updates that came out of ISC, research and trials, had an examination by one of our physicians and our neuroscience transfer coordinator on the United Stroke Scale exam. Really positive feedback on that, even with our stroke coordinators who are tasked with the annual stroke education as their primary stroke centers, found it to be extremely beneficial and something we're looking to build on from a module standpoint. And again, I'll talk about that in some of the near-term work that we'll be doing. We also had our network members present. We looked at who our leaders were in things like door-to-needle or TPA rate. So some of that the shared challenges, who had a workflow, where were they getting pushback? How did you address a pharmacy that's making things challenging for you from a stroke perspective? And they were able to go back and share that with their leaders. Of course, we did have some service line leaders in the room. So again, fighting the same fight. Great to bring that group together, and something we'll continue to do on an annual basis. So looking ahead, what's next? We identified some gaps. Data collection is the biggest one. Right now we have, as Jim mentioned, 86% of our patients remain in the originating site for their care. And as of right now, we have very little or no visibility to outcomes for those patients. So we've just started a process within the past year of actually gathering feedback and data from our spoke sites. So the key highlights on that are door-to-needle times, what was the final diagnosis, any complications, discharge disposition, ideally if we're able to get the final NIH stroke scale score. And this is a huge population of our patients that we have not been able to report out on. For those of you that may use some other systems, just as a reference, we have an internal system that we use for tracking, and we use the independent hospital EMR and PACS system. So we are actually moving towards the InTouch clinical application platform, and this will be something that we'll be looking to be able to capture through that platform, and then a lot of our reporting will be ensuring that we can replicate that based on that clinical apps platform. So patient feedback, I mentioned the letters that go out on a monthly basis. We just have not felt that these were particularly timely or necessarily meaningful based on the audience that was receiving them. So your stroke program coordinators, your emergency medicine directors. So we're actually looking to transition, we're working through with our risk and compliance teams, to a call that would be placed on any neuroscience transfer. If a patient receives a procedure, ideally we look to start with that group within 48 hours. So you get an immediate feedback. We'd have a designated appointee at each site to receive this information on the patient. Did they receive mechanical thrombectomy? Were they entered into a trial? Where's their care continuing? Instead of those letters that I mentioned that were further delayed or also de-identified based on our risk and compliance regulations. Our endovascular team, we've talked about this with them in the past. They've been much more open more recently about generating report cards for those patients who do go for endovascular care, having the pre and post angio highlighting the times, outcomes, and this report card would be sent to an audience internal here at Rush. We have a similar report card that we already send out. Would include EMS, would include our spoke partner site, anyone that's involved in the care. These are great feedback tools. We know a number of other programs already utilize them. A great way to highlight the highest level of care that we can provide, and again, enabling your partner sites to post these in the emergency department, share at their stroke committee meetings, and highlight what they're doing within stroke for their patients. Lastly, a dashboard would in some ways replace the letter that we're sending out on patients that highlight benchmark length of stays, transfer times, would hopefully highlight if there's areas for improvement. And this wouldn't just be for telestroke patients. We'd be looking at all neuroscience or rolling up with our transfer center for all transfer patients. As far as education goes, we actually just had a meeting this morning talking about what we can do. We've been very heavily focused within the implementation phase for our in-service, and then just catching new staff, doing our annual check-ins, and realize that there's a bit of a gap that we may be able to leverage some of the resources that we have here at Rush, some of that required stroke education, online resources. There's a number of them out there. You're probably aware of sending to our sites as they have to get required education. But developing customized videos, and just as an example, one of the challenges that we run into with the examination in the emergency department is visual field testing. So we have a nurse or a tech, someone from the ED present throughout our exam, and this may be someone that has gone through their stroke education every year but is not often asked to truly do visual field, or is comfortable doing that and understanding what observations our vascular neurologists need to make to that examination. So looking to actually develop some video modules, things that could be sent to our spoke sites, something that could then be played over the robot if we're doing education within the ED. So either could be led by our team or led by the spoke site team. Beyond an actual exam need, just highlighting workflow, some of the pieces that go into our general in-service, actually having some canned videos that could be included with some of the education and interaction that we do on site. So that's something we expect to have here within the next few months. So lastly, I'll hand it back to Dr. Connors to talk about one of the more exciting additions to our stroke program.
Great, thanks, Josh. So, what's next in the clinical area of telestroke? One of the things that we always look at is our door-to-needle times, and those improvements can really only go so far. Now, we have door-to-needle times that's in some hospitals reporting under 20 minutes on certain occasions. But what's really happening before the patient even gets to the door, right? So what's happening from when the onset of stroke symptoms occur until they get to the ER? And can we improve the onset to treatment times, really overall, improving outcomes? And when we look at that, we say, one big thing that I talked about earlier in some of the earlier slides is community education and awareness, recognizing a stroke, knowing when to call 911. EMS education is also very important. They need to be able to recognize patients that are having stroke in the field, especially when we're developing other systems of care looking at specific triage of patients. So many of you are probably in areas where there's triage specifically to stroke centers. We're also looking at triage to comprehensive stroke centers if EMS can recognize patients with potential large vessel occlusions in the field. So what else can be done? Well, this is the new area that I thought would be interesting to discuss just on the next couple of slides as we wrap things up, but mobile stroke units and how is it that they can play a role with telestroke. So what is a mobile stroke unit? It's obviously new technology, but basically it's an ambulance that's outfitted with a CT scanner as well as telemedicine capabilities. The the ambulance would get dispatched after a 911 call that had suspicion of stroke symptoms. Again, dispatched at the same time as the regular EMS in that area. On board then, the patient, if it's a suspected stroke, would actually have a telestroke consultation on the unit using the remote monitoring. They would be able to do the CT, as I mentioned, and then the stroke neurologist can diagnose and treat the patients on the scene, so giving TPA also in the field. And this is, again, administering TPA in the pre-hospital setting. This is started off in Europe, and now it's being done at select locations within the U.S. In addition to giving the TPA, we also have the ability to potentially identify large vessel occlusion patients, again, those patients who might require comprehensive care right there in the field rather than waiting until they get to a primary stroke center and then transferring later. So really, in essence, this is, again, utilizing telemedicine to improve outcomes. We look at this as a further extension of our overall telestroke program. This one happens to be with our CT scanner and our telestroke capabilities within an ambulance. Again, very similar to our normal telestroke program, we're doing rapid assessment of the stroke patient and then giving them TPA, but again, now this is before they even arrive in the emergency department. So really cutting down on that onset to treatment time, and we know that that should improve outcomes. In addition, as I mentioned, this should avoid some of those hospital-to-hospital transfer delays. When we looked at it within our system in the city of Chicago, typically when a patient would arrive in an emergency room with stroke-like symptoms, and then if they're recognized as a potential large vessel occlusion by the time they had their workup at the outside hospital, the comprehensive stroke center is called and they're transferred, that average time is about 2 hours. And so you can imagine if you're able to actually make a good diagnosis in the field, you're really saving that person 2 hours worth of time as far as being able to be treated. And so we know that that should also have a significant impact on overall outcomes. And then, finally, it's really determining are there opportunities outside of ischemic stroke. So, certainly as we're picking up these patients, there's going to be patients who have intracerebral hemorrhage, who may or may not be on anticoagulation, other medications. They might have elevated blood pressure. And so, again, being able to treat some of these additional stroke patients before they even arrive in the ER, and again, with the overall idea of improving outcomes in our patients. So it's an exciting time to be working in the stroke field, and I just want to thank everyone for their time. I think we'll open it up to questions.
Thank you both. We'll begin the question answer portion now. Feel free to get your questions in using the Q&A widget located on the audience console. Dr. Connors and Josh, we do have one question come in right now. What denominator are you using for rate of TPA? Is it TPA given over total number of telestroke consults regardless of final diagnosis, or the number of those consulted arriving in a 4.5-hour or less period?
Yeah, that's a great question. That TPA rate number is definitely a moving target. The denominator that we use, our physicians identify just a quick yes-no within our tracking for whether it was a stroke diagnosis, regardless of time. So our denominator would be any patient that's identified as having a stroke diagnosis or TIA. So if a patient presents and it's a seizure, they would not be included within that denominator.
Right, and I think that with the idea that our overall telestroke population, about a third of our consults, after we see the patient, we determine that as a stroke neurologist, we didn't think it was a stroke or TIA to begin with. So, certainly you see a lot of patients who end up having seizures, complicated migraine, et cetera. And so this is, it's based on patients who we actually think had an ischemic stroke, but regardless of time.
Great. We have another question. Are you using any other scoring like RACE for LVO?
Yeah, right now, that's a great question. Right now, we're looking at that as a system. So regional EMS system is looking at various scales, looking at the 3-item stroke scale score. With telemedicine, we're really basing it off of, we have a stroke neurologist who's seen the patient, and we're basing it off of the more detailed neurologic exam. The exam that we're using is really oftentimes very similar to just doing the NIH stroke scale score, but so you can look at a total number, but then again, it has to be, you can have a relatively high number where it still, appears to be more of a lacunar syndrome, as opposed to, excuse me, even a lower number, but if that patient has cortical signs, any suspicion that it could be a large vessel occlusion from the stroke neurologist standpoint, that's what we're using. And I think in those in-between cases, we've had a lot of discussion lately of getting the CT angiogram at the spoke site, and just making sure that we can do that rapidly, because we certainly don't want to have a significant delay in getting those patients transferred.
Great. Another question. Do you see a role for a telehealth-equipped ambulance without CT scanner?
I think that's certainly another possibility. If you have the telehealth equipment and not the CT scanner, you're going to be able, I think it'll help with triage, especially looking at, do we think this is potentially a large vessel occlusion? You're not going to be able to rule out the hemorrhages, so certainly you won't be able to treat with IV-TPA. You're probably not going to improve those, door to TPA treatment times, but it certainly can help with the overall triage. So I think for those patients who, we're talking about, recognizing a large vessel occlusion or just severe stroke symptoms, which could also be reflective of ICH or a subarachnoid hemorrhage patient, then there certainly could be benefit there, and you're certainly reducing the cost by not having the CT scanner on board.
It looks like we have one more question. What have patient reactions been like with remote stroke care?
I can say that it's been very good. I don't think we've ever had a single patient complaint. I think that patients and their families appreciate the fact that they're being evaluated by an expert in the emergency room, and by the fact that it happens so quickly. So, consult times in an emergency room can vary quite a bit, but certainly if somebody's, a patient's sitting in your ER and they're being told, well, we're just waiting for the specialist to come in and evaluate you, when that specialist then is beaming in within minutes, and our response times are about 6 minutes from the time that we're called until we're actually seeing the patient, they really appreciate that. And with the InTouch system, we're able to really, it does seem like you're in the room, because you can move the camera side to side. I can talk to anyone in the room. And so it's been a great workflow from our standpoint, and I think, like I said, the patients really appreciate being evaluated. They like the fact that they're being seen by an expert in the field, and so it's been all positive impact, or all positive feedback.
Yeah, that's something we've also, during the implementation phase, we work with each of our sites on messaging, whether they have had telemedicine previously or not, making sure that the clinical teams within the emergency department are comfortable speaking about telestroke, highlighting exactly what Dr. Connors just mentioned, that they're getting a stroke expert immediately, that potential therapy is time-dependent. So that rolls up into the in-service and implementation that we do anytime we bring a new site on board, or if there's new staff. So we felt like that has been a positive for that team to be comfortable with it as well.
Great. It looks like that's all the questions we've gotten so far. We'd like to give a big thank you to Dr. Connors and Joshua for today's presentation. If you have any additional questions or would like more information, please contact us at feedback@intouchhealth.com. And also visit our website to find a recording of this webinar and a list of upcoming webinars in our series. Again, thank you, Dr. Connors and Joshua, and have a great day.
Thank you.